Welcome to This Week in Pulmonary and Critical Care Medicine. I'm your host, Aladdin Sagar. For busy clinicians, this brief weekly update is designed to do one thing well: distill new, practice-relevant pulmonary and critical care literature into a clear, balanced, and clinically grounded narrative. No hype, no shortcuts. Just what changed, what it means, and where the uncertainty still lies. This week, we cover 3 studies that span outpatient pulmonary disease, ICU physiology, and procedural practice. First, a large population-based chest study examining whether PRISm behaves differently depending on smoking status, challenging the assumption that PRISm is primarily a smoker's phenotype. Second, a multi-center physiological study evaluating whether changes in inspiratory effort and respiratory mechanics during spontaneous breathing trials can predict extubation failure in high-risk patients. And finally, a comprehensive narrative review outlining practical, evidence-informed techniques to improve success with ultrasound-guided radial artery catheterization. As always, this podcast is for education. It summarizes published data, highlights strengths and limitations, and aims to support, not replace, clinical judgment. Let's get started. Published in Chest, this study by Dye and colleagues asks a deceptively simple but clinically important question. Does preserved ratio impaired spirometry, or PRISm, behave differently depending on smoking status? PRISm is defined as an FEV1 less than 80% predicted with a preserved FEV1/FVC ratio of at least 0.7. It has long been considered a potential precursor to COPD, but controversy remains over whether PRISm in never smokers represents the same biological risk state as PRISm in individuals with smoking exposure. Some have even proposed restricting the term PRISm to smokers only. This study directly challenges that idea. The investigators analyzed data from a 15-year population-based prospective cohort in China, including 2,850 participants aged 40 to 80 years with longitudinal spirometry. Importantly, individuals with established airflow limitation at baseline and those with normal spirometry who had ever smoked were excluded. Participants were categorized into 3 groups: never smokers with normal spirometry, never smokers with PRISm, termed NS PRISm, and ever smokers with PRISm, termed ES PRISm. The first key finding relates to lung function decline. Somewhat counterintuitively, the normal control group exhibited the fastest annual decline in lung function, followed by the ES PRISm group, while the NS PRISm group showed the slowest decline. However, within the PRISm population, smoking status clearly mattered. Participants with ES PRISm experienced significantly faster lung function decline than those with NS PRISm, reinforcing the biological impact of smoking even when airflow obstruction is not yet present. The more clinically consequential finding concerns progression to airflow limitation. Over follow-up, 37.1% of the ES PRISm group developed airflow limitation, compared with 14.7% in the NS PRISm group and 9.1% in normal controls. After multivariable adjustment, ES PRISm was associated with nearly double the risk of developing airflow limitation compared with NS PRISm, with an adjusted hazard ratio of 1.90. Compared with normal controls, the risk was even higher, with an adjusted hazard ratio of 2.69. Crucially, NS PRISm was not benign. Never smokers with PRISm still had a significantly higher risk of developing airflow limitation than normal controls, with an adjusted hazard ratio of 1.41. When the ES PRISm group was further subdivided into current and former smokers, both subgroups demonstrated similarly elevated risks compared with NS PRISm. From an editorial standpoint, this study does several things well. The cohort is large, follow-up is long, and the exclusion criteria help isolate PRISm as a true intermediate state rather than early COPD. The consistent signal across adjusted analyses strengthens the findings. At the same time, there are limitations. Spirometry was performed pre-bronchodilator, which may misclassify some individuals. The cohort is geographically and ethnically homogeneous, which may limit generalizability. And while progression to airflow limitation is a meaningful outcome, symptom burden, imaging progression, and mortality were not the primary focus here. Still, the clinical message is hard to ignore. PRISm, even in never smokers, is not a trivial finding. While smoking clearly amplifies risk, the absence of smoking does not confer protection. Restricting PRISm evaluation to smokers alone would miss a substantial at-risk population. For clinicians, this argues for thoughtful longitudinal follow-up and risk modification strategies in all patients with PRISm, not just those with a smoking history. Published in the American Journal of Respiratory and Critical Care Medicine, this multicenter study by Margolo and colleagues addresses a persistent problem in ICU practice. Why do some high-risk patients fail extubation despite passing a spontaneous breathing trial? Current weaning criteria emphasize respiratory rate, tidal volume, gas exchange, and hemodynamics. Yet these markers often fail to capture evolving respiratory distress, particularly in patients at high risk of extubation failure. This study explores whether non-invasive measurements of respiratory mechanics and inspiratory effort during spontaneous breathing trials can better predict outcomes. The investigators conducted a prospective, multi-center observational study across 5 ICUs in Italy. They enrolled 238 mechanically ventilated patients deemed at high risk for extubation failure, defined by factors such as age over 65 or underlying cardiac or pulmonary disease, who successfully passed a conventional 30-minute SBT using pressure support ventilation at 7 centimeters water and PEEP of 5 centimeters water. After this initial successful SBT, patients underwent a second standardized SBT using proportional assist ventilation to allow continuous measurement of respiratory system compliance, inspiratory effort measured as airway pressure drop during end expiratory occlusion, known as DPOCC, and respiratory drive. All patients were then extubated and followed for 72 hours. 19% of patients, 46 out of 238, provided reintubation within 72 hours. Importantly, traditional parameters such as tidal volume and respiratory rate did not differ between those who succeeded and those who failed extubation at any point during the SBT. This finding alone reinforces a key limitation of current weaning practices. Physiological measurements told a different story. In patients who were successfully extubated, normalized respiratory system compliance remained stable throughout the SBT, and inspiratory effort did not increase. In contrast, patients who ultimately required reintubation showed a significant decline in compliance, from a median of 1.0 to 0.7 milliliters per centimeter water per kilogram, and a marked increase in inspiratory effort, with DPOC rising from 12 to 18 centimeters water. Both changes were highly statistically significant. The predictive performance was striking. An increase in DPOC greater than 2 centimeters water during the SBT predicted extubation failure with a sensitivity of 89% and a specificity of 93%, yielding an area under the curve of 0.94. A decline in normalized compliance also performed well, with an area under the curve of 0.90. By contrast, respiratory drive increased in both groups and was less discriminatory. From a physiological perspective, these findings make sense. Rising inspiratory effort reflects increased respiratory muscle load and potential diaphragm fatigue, while declining compliance may indicate derecruitment or worsening lung mechanics during unsupported breathing. Neither phenomenon is captured by tidal volume or respiratory rate alone. The strengths of this study include its multi-center design, standardized measurements, and focus on high-risk patients, the very population in whom extubation decisions are most consequential. The use of non-invasive techniques applicable to most modern ventilators enhances clinical relevance. There are, however, important caveats. The SBT used was relatively easy, potentially underestimating post-extubation work of breathing. All patients received high-flow nasal cannula after extubation, rather than prophylactic non-invasive ventilation, which may partly explain the relatively high reintubation rate. And while the physiological associations are compelling, this was not an interventional trial. Clinically, this study does not mandate immediate changes to extubation protocols, but it strongly suggests that monitoring inspiratory effort and respiratory mechanics during SBTs could help identify patients who appear ready by conventional criteria, yet remain physiologically vulnerable. Whether acting on these signals, by delaying extubation or tailoring post-extubation support, improves outcomes will require future trials. Published in Journal of Anesthesia, Analgesia, and Critical Care in 2025, this narrative review by he and colleagues addresses a deceptively practical problem. Why does ultrasound-guided radial artery catheterization still fail, and how can we do better? Ultrasound guidance is well established to improve success rates and reduce complications compared with palpation, with prior data suggesting a 20 to 30% improvement in first attempt success. Yet failure rates remain meaningful in certain populations, including pediatric patients, the elderly, those with obesity, hypotension, or chronic kidney disease. This review synthesizes nearly 3 decades of literature to identify modifiable factors that can further improve outcomes. The authors conducted a structured narrative review of studies published between 1992 and April 2025, ultimately including 49 articles, most of which were randomized clinical trials. Rather than focusing on devices alone, the review organizes techniques into 4 domains: plane-needle relationship, ultrasound probe optimization, patient-related arterial factors, and insertion needle strategies. One of the most practically valuable sections concerns plane needle alignment. Techniques such as dynamic needle tip positioning and combining long axis in plane with short axis out of plane approaches consistently improve visualization of the needle tip, reducing posterior wall puncture and increasing first pass success. These methods require skill and practice, but no additional equipment, making them immediately actionable. Probe-related innovations also show promise. Scaled probes with millimeter markings help localize superficial arteries more precisely. T-type probes allow simultaneous short and long axis visualization, reducing the need for probe manipulation. More experimental approaches, such as laser-assisted guidance or head-mounted displays, demonstrate improved success rates but face practical barriers related to cost and availability. Patient-level interventions are particularly interesting. Subcutaneous nitroglycerin, for example, has been shown to increase arterial diameter and improve first attempt success while reducing complications, including in pediatric populations. Injection of small volumes of saline to increase the depth of superficial arteries can markedly improve visualization and needle control. Median nerve block has been associated with vasodilation and improved cannulation success in selected studies. Finally, the review discusses insertion needle considerations, including catheter size selection based on measured arterial diameter and the use of guide wire assisted techniques in difficult access cases. While these strategies are intuitive, the review appropriately notes that high-quality comparative data remain limited. From an editorial perspective, the strength of this review lies in its organization and clinical pragmatism. It avoids overclaiming and clearly distinguishes between techniques supported by randomized trials and those based on smaller or observational studies. Its main limitation is inherent to the narrative review format: heterogeneity of included studies and the absence of pooled effect estimates. For clinicians, the takeaway is not that a single technique guarantees success, but that failure is often multifactorial. Improving outcomes requires attention to needle visualization, probe handling, patient preparation, and catheter selection. Even incremental improvements in first-pass success can meaningfully reduce complications and procedure time, particularly in high-risk patients. This week's studies remind us that risk often hides in plain sight. PRISm in never smokers is not benign. Spontaneous breathing trials can look reassuring while physiology quietly deteriorates. And even routine procedures like arterial cannulation benefit from deliberate technique rather than habit. Each of these papers advances care not through dramatic interventions, but through better classification, better measurement, and better execution. At the same time, they all leave open questions about generalizability, thresholds for action, and how best to translate physiology into outcomes. If you found this episode useful, consider subscribing so you don't miss future weekly updates. As always, these summaries are educational and should be interpreted in the context of individual patients and evolving evidence. Thank you for listening to This Week in Pulmonary and Critical Care Medicine.